morning all. Thank you very much for the invitation. I'm going to try to cover eyelid reconstruction in 9 minutes, so I'll do my best. So we'll just discuss a few general considerations. I'll talk you through my process of thinking when I see a lower lid defect, and I'll also show you lots of pictures about the reconstruction work that I have done. Please, no photography is allowed. Those patients have not been consented for publication. So as we know, the reconstructive work is really an art. It's not a science you can read. You can learn by reading books or seeing pictures or watching YouTube. Each defect is unique. There are several factors you have to think about when you see any defects. So the depth, the size, the state of the surrounding tissues. So these are important things, as well as other minute things you have to keep in mind. It's unfortunately a very difficult skill to acquire in this part of the world due to the very low incidence of skin cancers. But it's a skill that we all have to have some knowledge of. We all do on calls, and we uncommonly see these cases, but we do see them, and you need to have some basic skills to be able to manage those patients safely. So I think the most important thing you have to take out of this presentation is that you have to think of the eyelid as two structures, two layers. There's the anterior lamella and the posterior lamella, and you have to think about your reconstruction in two different layers completely. So each one has to be reconstructed differently. And as a reconstructive surgeon, you have to be aware of all the important structures around the eye and the periocular area, blood vessels, nerves, and the lacrimal system as well. You also have to keep in mind some of the factors that may influence your healing process. So, for example, shrinking of scarring tissue or shrinking of a skin graft. You have to also bear in mind the effect of gravity, especially when there is a lot of tissue laxity. These are some of the general surgical principles you have to be aware of when you do your reconstructive work. So as we know, the classical teacher never reconstruct vertically and always try to close horizontally to avoid scar tissue like tropion. You have to be very generous with your subcutaneous tissue closure in order to reduce the skin tension and get a better scar, and have a very low threshold to tighten the eyelids if you're doing any lower lid work when it's appropriate. Okay, so this is my simplified method of thinking when I see a lower lid defect. So that you can start, depending on the side of the defect, with a direct closure. This is a lady that has a small basal cell carcinoma in her lower lid. So following excision, that's what she has. She has a kind of a relatively small defect. And my tip to you when you see those defects is to try to overlap the two edges of the defect. If you can overlap by 1 or 2 millimeters, then your direct closure is going to lead to a very good result. And obviously, the utmost important in these in direct reconstruction is to place your cardinal suture appropriately, same level, and you have to really aim to get a symmetrical and perfect alignment of the eyelid, and have a very low threshold to undo the suture and put it again if needs to be. So you need to have perfect alignment, as I said before. It's not unusual to have a little sort of notch in the beginning when you put your first suture, but this will correct when you close the rest of the tarsus. Put it on a releasable suture so you can undo it if needs to be. So you can see the notch has now gone following the placement of the 3 tarsus sutures, and then at the end you finish off by putting the gray line suture, which will produce a little bit of a hump in the area, and you can see there the patient post-operatively is a slight edema, slight thickening, but that tends to settle in a few months' time. If there is any difficulty getting the two edges to meet, then you can probably do a canthotomy and cantholysis. This will help to reduce the remote tension by cutting the inferior limb of the lateral canthal tendon, and will allow you to perform a direct closure without tension. Tension will lead to notching and wound dehiscence and cheese wiring, so be very careful with that. Okay, then you will, when you do a canthotomy cantholysis, you may get a little notch laterally. It's not normally of any great cosmetic or functional impact. And if the defect is a little bit bigger, then perhaps you can consider performing a tensile flap. A tensile flap is an anterior lamellar flap, so it helps to reconstruct an anterior lamellar defect. It's a semicircular flap that you can use the excess tissue, skin in the lateral canthal area, and slide it nasally to cover a defect. You can do a direct closure, and that will help to cover the posterior lamellar defect. And it tends to heal really very well. I mean, the scarring, I mean, this is the patient I've done. You can hardly see the scar there, and it's a very good outcome. However, you may get blunting of the lateral canthal tendon, especially when you do canthotomy cantholysis. To avoid that, you can do a periosteal rotation flap. I haven't put pictures of that because of the sake of the presentation. It's only 9 minutes I have. But to avoid this blunting of the lateral canthal tendon, you can augment the lateral canthal tendon with a periosteal rotation flap. When you have a substantial eyelid defect, you obviously have to replace the lost tarsal tissue, and you have a variety of options. So you have flaps, you have grafts, you have other things you can put in the area. In my practice, the most popular one is Hughes flap, and this is how a Hughes flap works. So this is a patient that lost most of his lower lid, and there's only a lateral stump, and what I did there was just burrowing some of the tarsal tissues from the upper lid on a conjunctival pedicle, so it's a flap, and then you suture it sideways, and then obviously this will sort out the posterior lamellar defect, and then you have to exercise your creativity in redesigning or reconstructing the anterior lamellar defect. So you have a variety of options. You have a finger transposition flap from the upper lid, so if somebody has a lot of skin in the upper lid, you can mark a safe blepharoplasty incisions and then burrow the skin on a lateral pedicle and move it down, and that really produces very good results. This is how it looks. So the upper lid wound, you can see it there, and I've used the skin from the upper lid to reconstruct the lower lid. This is how it looks post-operatively, obviously following division of the Hughes flap. You can perhaps use other methods of reconstructing the anterior surface, the anterior lamella, for example, a finger transposition from a flap from the cheek. So you can move it upwards to reconstruct the anterior lamellar defect. You can do a rotation flap using the skin in the cheek and the lateral canthal area, rotate it nasally to cover a defect. So that really works very well as well. And obviously, lastly, you have the option, the lazy option, I would say, of a full thickness skin graft. If you're stuck with the anterior lamella, and if you have a good base, then full thickness skin graft is always an option, and that really works very well. My worry with the Hughes flap is once you've put your tarsal plate, it doesn't have a lot of vasculature, so I try whenever possible to avoid putting a full thickness skin graft, but sometimes you have to. So in summary, as I discussed before, try to understand the anatomy of the eyelid, the anterior and the posterior lamella, and try to mimic the anatomy. So always be careful when you move tissues from one unit to another unit. So the eyelid has 4 units, upper, lower, medial, and lateral. And you saw the patient that I do the flap from the cheek. It's a little bit thickened, so always keep that in mind. And it's always essential to assess the surrounding tissue. So if you have skin in the upper lid, excess skin in the upper lid, you can use to reconstruct the lower lid. If you have excess skin in the lateral canthal area, you can move it to reconstruct an anterior lamellar defect. Keep in mind all the involutional changing. The scar and the full thickness skin graft tend to shrink with time, so keep that in mind. Gravity, always pull things southwards. So if you need to tighten the lower lid, please do. It's essential to prevent cicatricial ectropion. And lastly, be creative with your anterior lamellar work. There are so many options, and your way may look good, but there are other ways of doing it as well. That's brilliant. Thank you very much, and I think I'm just on time.